So good afternoon or good morning to you, depending on where you are. Thank you for joining us. This is the National Center for Health and Public Housing. We are going to be discussing our third learning collaborative session on this expanding diabetes prevention and management through health center outreach learning collaborative. At this moment, next slide. At this moment, this is a live event, so all participants are muted. Since this is a very small group, if you have your camera and you can turn your camera on, so we can have a better discussion and engage more in this particular topic. There are several ways that we can engage. Either you can use the chat, type your question or your comments, or you can use the reactions. And if you click on the reactions, you will see that there is that raise hand. So if you raise your hand, you can also can be unmuted. The slides and recording will be sent via email within a week after this discussion and post-evaluation survey. We would like to hear from you about this learning collaborative and whether, and ways that we can have to either improve our learning collaborative or add additional information or training and technical assistance sessions or new topics or emerging topics that you are seeing at your health center sites. So if there's anything else, please type your questions or type your comments again in the chat box. Next slide. You can also access Moodle. If you go to moodle.nchph.org and select Expanding Diabetes Prevention and Management through Health Center Outreach Learning Collaborative, you will find all the resources and the welcome packet and all the materials related to this learning collaborative. If you are new and you haven't created, if this is the first time that you are participating and you haven't created your Moodle account, you can go again to moodle.nchph.org and then create your account. You will have your username and your password, and you will have access to all the materials that we are right now sharing with all participants. Next slide. We are the National Center for Health and Public Housing. We provide training and technical assistance to community health centers. Specifically, we focus a lot on health centers located in or immediately accessible to public housing. However, the recommendations and best practices and everything that we are discussing is useful for all health centers serving different special and vulnerable populations. We are funded by HRSA to provide training and technical assistance, and the comments are not necessarily do not necessarily represent the official views of the Health Resources and Services Administration, HRSA. Next slide. Again, my name is Jose Leon. I am the Chief Medical Officer for the National Center for Health and Public Housing. And with me and working on the logistic is Fide Pineda Sandoval. She is the NCHBH Research Assistant, and she will be working on the logistics and all your needs. In case you need any assistance, you can reach out to Fide. It's my understanding that we have a new participant. If possible, you can either use the chat box or your line can be unmuted, and just let us know your name, your health center name, and the location and the number of clinical sites. All right. This is just a quick reminder of the National Center for Healthy Public Housing and the health centers located in or immediately accessible to public housing. There are 433 health centers located near or immediately accessible to public housing, and in 2019, they serve over 5 million patients. Out of the 433, 108 public housing health centers are public housing primary care grantees, and which means they receive funding from HRSA to provide services to public housing residents. And in 2019, they serve over almost 860,000 patients. Next slide. This is a very interesting slide. For the purpose of this presentation, I would like you to pay attention to two particular demographics here. One is the percentage of female-headed household with children in public housing. 33% are female-headed household with children. And this is something that we are going to discuss during our session. And the other one that is quite interesting is the last one in regards to low income. 93% of those living in public housing are below the poverty line. So in addition to all the demographic and social determinants of health on this slide, I would like you to pay attention to these two particular issues of the patients living in public housing, because this is going to be part of the discussion during the conversation that we're having so far. Next slide. Why is it important to discuss diabetes in health centers? HRSA established diabetes as a priority a few years ago, and in 2019, and again, this is based on 2019 UDS data, 2.7 million patients, or over 2.7 million patients are patient with diabetes, and this is for all health centers. And in public housing, 9.6% of public housing grantee patients have diabetes. Next slide. So again, this is our third session, and it's today we are going to discuss so far we have discussed the basics of diabetes. We have discussed issues concerning social determinants of health concerning patients with diabetes. So next slide. Today we are going to discuss food insecurity, the impact of food insecurity on diabetes prevention, the role of CHWs addressing food insecurity, and food insecurity screening tools. Next slide. So the learning objectives for today's sessions are: we are going to define food insecurity and describe those who are most affected. We are going to describe how diabetes and food insecurity impact diabetes-related health outcomes. We are going to describe the role of CHWs and the role that CHWs play in addressing food insecurity. Lastly, we are going to identify some screening tools and some resources within the communities. Next slide. This is going to be our case study. We are going to briefly discuss some options and some best practices of what you would do to help these patients. So today we are going to be discussing a patient MY is an African-American woman, 60 years of age, who was diagnosed with type 2 diabetes 16 years ago. Her history includes hypertension, which is currently well controlled on medication. The patient's body weight is 30 pounds above the ideal. Clinical signs of early renal failure, cardiovascular disease, and early stage retinopathy. She reports that her blood sugar never has been too good, and she doesn't think it ever will be. Lately, it's getting worse. In the assessment, you know that the patient MY's blood glucose has ranged from 43 to 383. milligrams per deciliter over the previous few months. So this is going to be our case study discussion. So we're going to have more information about our patient at the end of the presentation. Next slide. So let's start by defining food insecurity. And this is extremely important in public housing and all other special populations that health centers serve. And it's interesting to know that this basically the disruption of food intake because of lack of money and other resources. Now, USDA has two other categories, which is one is the low food security, and the patient basically reports of reduced quality and variety of desirability of diet, but there is little or no indication of reduced food intake. Whereas very low food insecurity is reports of multiple indications of disrupted eating patients and reduced food intake. Next slide. Now, when we discuss food insecurity, sometimes believe that all those with food insecurity have other issues, you know, like malnutrition or any other issues. But according to reports from federal agencies, food insecurity doesn't necessarily cause hunger, but hunger is a possible outcome of food insecurity. And this is extremely important to know, because we are talking not about a patient having malnutrition because lack of food or because the patient doesn't have is not eating well. It's just the inability to get healthy food, you know, or to improve, in this case, based on the discussion that we're having, diabetes management, or if the patient has prediabetes, is more likely if the patient has food insecurity to develop that diabetes. Next slide. It's interesting to see that, and this is a very interesting slide, because when we analyze percentages, the percentages doesn't really show the reality and the real conditions of patients. And this is the latest data that we have access to. And in 2019, 89.5% of the US households were food secure throughout the year. So that is a very good number if you consider that almost 90% of the households in the United States have are food secure. But when you look at numbers and when you look at percentages, it means that around 5.3 million households had very low food security in the United States. So you can say, oh, it's just a 4.1%. But that when you translate the percentage to real numbers, we see that almost or over 5 million households do not have access sometimes, or are food insecure. Next slide. The other issue affecting food insecurity is COVID. As we know, during the pandemic, patients have been struggling to either keep their jobs or to have stable income. And this is information from WHO. The World Health Organization is saying that at this moment it's too soon to assess the full impact of the lockdowns and other containment measures. But it's possible that in the world, as many as 132 million will go hungry in 2020 as a result of the economic recession triggered by COVID-19. So let's also keep this in mind, that COVID has also affected the ability of patients to secure food, especially if they live in food deserts. And the the ability of these patients to get access to food is extremely important when we're discussing diabetes, and that's going to be the discussion in regards to food insecurity. Next slide. So in the beginning, I said to pay attention to the slide showing social demographics. Specifically, we said that 33% of households are female-headed in public housing, and according to the Centers for Disease Control and the Economic Research Service, these are two independent resources. Food insecurity rates are highest for single mother households and households with income below poverty line. We also discussed when we saw the social demographics in public housing, we said that 93% of those living in public housing are below the poverty line. So as we can see, public housing residents in particular are more likely to have food insecurity based on the social demographic or social determinants of health affecting this special population. And it's about the same for other populations. People experiencing homelessness have exactly the same social determinants of health as well as those migrant and agricultural workers. But let's keep in mind that in those households where you have single mothers and when the income is below the poverty line, then we need to make sure that we assess food insecurity when you are having contact with your patients. Next slide. Now, in 2019, again, over almost 14% of households with children were affected by food insecurity. This is another important issue to discuss when we have patients with diabetes. The reason is that as we will see patients being affected by food insecurity, sometimes they try to make sure that their children have access to food, and sometimes they sacrifice their ability to get food for them in order to make sure that their children receive the food that they need. And that is going to have an impact on patients with either pre-diabetes or diabetes. Next slide. In the United States, southern states are more likely to have, those living in southern states are more likely to be food insecure. There are several reasons. One is the low income, but these sometimes are low income populations. We will see that at the same time we will have some ethnic and minority groups living in these states. We'll see that Hispanics and African Americans are also more likely to be food insecure. So if you are in one of these states, you have a better understanding and a better idea of how food insecurity affects your patients with diabetes. And this is across the board. It's not only southern states, but if you are serving, in addition to any of the special populations defined by HRSA, if you serve African Americans and those patients or patients, Hispanic patients, you'll see that they are more likely to have or to be food insecure. Next slide. So let's move on the intersection of food insecurity and diabetes. We have seen we have provided a general overview and we have learned about food insecurity, but what is so important, why is so important to see food insecurity in patients with diabetes? Well, according to the American Diabetes Association diabetes risk is 50% higher among adults in food insecure households. Food insecure adults are 2 times more likely to have diabetes, and food insecure pregnant women are at risk of gestational diabetes. So as a CHW, you have a better understanding of the needs of your patients and how you can assess food insecurity. But at the same time, it is very important to see that patients in general, and specifically the last item or the last bullet point I would have here, is that patients who are pregnant and so they have some kind of food insecurity are more likely to develop gestational diabetes, which means that in the long run, a patient with gestational diabetes can also develop diabetes or type 2 diabetes. Next slide. So there are different issues or effects of food insecurity and diabetes. One is food purchase planning and preparation. When patients are food insecure, they skip meals, they cut meal sizes, and they eat state food. In addition, adults eat less food so children can have enough. They purchase cheaper canned food and access to convenience. They have access to convenience store only. And what does it mean? It means that sometimes people who are food insecure are more likely to have high calorie meals and less proteins and less healthy fat, and then are more likely to have food with high concentration of carbohydrates, which means if we are talking about patients with pre-diabetes, they will be more likely to develop diabetes. And for those patients with diabetes are more likely to have uncontrolled diabetes. Next slide. So the impact that is going to have on diabetes management is that first, healthcare expenses exacerbate food insecurity. Food insecure people are more likely to delay filling prescriptions and reuse needle or monitor their glucose less often. They have to choose between healthy food, diabetes medications, supplies, and rent, and choose between food and medication. That can be a big issue because either the patients can develop hypoglycemia or hyperglycemia. And again, it will depend on the needs. The patient will have some time to make difficult choices. And the difficult choices will be reasons or will be factors for these patients to be or to have uncontrolled diabetes. If patients need to choose, for instance, between medications and supplies and rent, sometimes patients either do not have access to their medications, or patients cannot get the food that they need because low-income populations, again, are usually either underemployed or unemployed. So those are going to be issues affecting patients. And as CHW, you better than anybody know exactly the needs of your patients in your community. But these are issues that we need to assess every time that we have contact with our patients. Next slide. The effects on diet. The patient will consume fewer fruits, vegetables, and proteins, and rely more on high energy dense food. So the patient will have to, they will try to get food that are easier to get and cheaper. It is incredible to see that if you go to a fast food restaurant, to get any of these I don't know, hot dogs or hamburgers is cheaper than if you are trying to get fruits or vegetables if you go to a supermarket. So when patients are food insecure due to different reasons, because they do not have right now, they are low income patients, or they have at this moment, for instance, due to the pandemic, they are unemployed. They tend to eat or they tend to go to places where they can get only high energy or high calorie food, and that is going to affect their metabolism. And therefore, if the patient has diabetes, what is going to happen is that the patient it will develop uncontrolled diabetes. And in regards to glycemic control, food insecure diabetes patients have higher A1C levels, and the weight in regards to the effects on weight is that food insecure diabetes patients have a higher average BMI. Again, these are patients that instead of getting, let's say, the standard 2,000 calories, depending on whether or not the patients are exercising and all the other factors, the patient will consume those high calorie food, and what is going to happen is they will end up having a consumption of 3,000 calories, and most of them are not proteins, are not healthy fats, and they do not get the nutrients that they need. Next slide. Now, when patients are food insecure, is going to, food insecurity is going to affect not only diabetes, but other preconditions of comorbidities. Generally, patients we're going to have poor control of blood pressure, or if they have any other conditions, either kidney disease or cardiovascular disease, patient will also be affected. And then they will have if they cannot get their diabetes medication, probably they won't be able to secure the medication that they have for their blood pressure, for instance. These patients are more likely to go to the emergency room and have overnight hospitalizations. We've been talking about hypoglycemia and hyperglycemia in these patients. And that is going to be one of the factors why patients have to go to the emergency rooms to get healthcare services. These patients are also more likely to have mental health issues such as anxiety, shame, feeling of powerlessness, and depression because of all the psychological issues behind the ability of these patients to get food, not only for them but for the relatives in general, children and those living in the same household. Next slide. So let's move on to the role of CSWs on food insecurity. In the past, at the pre-pandemic activities, CHWs are, this still applies, but there have been some changes and probably some best practices, and we will have to, we've been able to somehow adapt to some other needs during the pandemic, but in general, CSWs identify patients with or being affected by food insecurity. They create awareness of programs, and they link patients to food assistance programs and refer patients to clinics or to the clinic. During the COVID-19 era now, there have been some best practices like food drive-ups or forced drop-off. We've been in contact with some health centers, and these health centers have been able to provide these services and making sure that the patient receive the food that they need by doing these drive-ups or going to the public housing developments, for instance, and working with the public housing leaders and the public housing agencies and making sure that they are able to provide some assistance to the patients and just do the drop-off for these communities. Next slide. So let's go back to our case study. Again, we are going to be discussing our patient MY. She's an African-American woman, 62 years of age, who was diagnosed with type 2 diabetes 16 years ago. Her history includes hypertension, which is currently well controlled on medication, body weight of 30 pounds above ideal, clinical signs of early renal failure, and cardiovascular disease, an early stage of retinopathy. She reports, quoted, "My blood sugar never has been too good, and I don't think it ever will be. Lately, it's gotten worse." The assessment is that the patient's blood glucose has ranged from 43 to 383 during the previous few months. And next slide. So the patient MY indicates that she has a good understanding of basic principles of meal planning and that her family is generally supportive of her dietary needs. However, because of the pandemic, she is not working full time and hasn't been able to secure healthy food. She skips or delays meals, and in some cases, and she eats large amounts of at other times. In apparent frustration, she states, "It seems I have to decide between my rent, my medicines, and provide food to my children." So let's open up our discussion. And in addition to what we have seen, that what other social determinants of health will you assess on this patient? So you can either participate by using the chat box and just adding your comments, or you can also go to the reactions again at the bottom of your screen and use the raise hand, and then your line will be unmuted. Anybody who would like to chime in and provide your experience with patients having or being affected by food insecurity, and what other social determinants of health you would like to assess when you have patients with food insecurity, in addition to probably the ones that we have mentioned, housing or education or access to programs, whatever you have been doing for these patients.
So we received some feedback through the chat, Dr. Leon.
Okay.
So by Diana Chavez, he says, "I am assuming in regards to the SDOH, transportation accessibility and economic stability. Those are some of the social determinants of health that would be assessed." And for Caitlin Kisla, she's saying location to the nearest food sources. So I believe maybe that would be in regards to where their patients would be referred to.
Thank you, Fide. And this is extremely important. Thank you for your feedback. Diana, transportation definitely is a huge issue, not only in rural areas, but in urban areas. In public housing, for instance, there is a percentage, a good amount of people with disabilities, for instance, who may not have access to transportation, and in order for them to go to any of the clinics or to have access to healthy food, even to go to a supermarket, this is a big issue. Thank you so much for that, because it is extremely important, and this is one of the biggest concerns right now during the pandemic, that patients are unable to go to either the clinic or go to supermarkets or places where they can have access to healthy food. So this is extremely important to consider when you are providing services to your patient. And Kathleen, locations to the nearest food sources, that is also a big issue. I remember going to a health center in Chicago, which is located in a suburban area in Chicago, and there are no supermarkets close to these public housing developments. So basically, they are located in what is considered a food desert, and for them to have access to healthy food is very difficult. And in addition to that, the programs, that they can have access to are far away from where they live. So it's extremely important, to make sure that we provide the nearest locations for these patients.
We also received another response, Dr. Leon, from Valiana. And she was referring to, in regards to what type of referral would you offer for housing, medical assistance and transportation, and also health insurance, food banks, education, and anything that's financial related.
Thank you, Valiana. That's extremely important as well in regards to referrals. Again, some of the health centers we've been in contact, or we are in contact with, they provide either supportive housing for patients experiencing homelessness, for instance, or they work with public housing agencies to make sure that patients that doesn't have a place to live can access to any of the HUD programs, and so they have access to a stable housing. Now, in regards to education and referral to diabetes self-management, education and support programs, that's extremely important as well. In addition to addressing all the social determinants of health, we need to make sure that the patients understand the diabetes, the complications, and the basic information that they need. Because even if the patient is able to get access to food and address some of the social determinants of health through the clinic, the patient also needs to have a better understanding of their condition, and not only diabetes, but hypertension, as we mentioned, cardiovascular disease, have access to a specialist, for instance. In this case, the patient has developed a retinopathy due to her type 2 diabetes. As a CHW, you need to make sure that patient has a better understanding of the complications, the diabetes complications. Now, in regards to, sorry, Fide, can you go back? I would like to focus a little bit on the bullet point, or the numeral 4. What resources does your health center have in place for patients experiencing food insecurity? So again, you can use the chat box, or your line can also be unmuted if you would like to participate and provide live information to others participating on this session. All right, let's move on. We are going to see some example. Oh, here it is. We have one. Here from the
Yeah.
line.
Yep. So we have one refer to a local food bank. Refer to local food banks encouraged to apply for food stamps. That is one of the programs provided by Valiana.
Thank you, Valiana, for sharing that information. Yeah, food banks are also a very good resource for our patients. Does anybody have like food pantries? Do you provide those services? I am just curious about food pantries. Again, we've been visiting some of the health centers and they have food pantries and they help patients with food insecurity. Anyone here attending? Okay, thank you, Valiana. So Valiana says that they do not provide them, but have them local. Okay, excellent. Thank you so much for that that information. So let's move on, Peter. So here we have some examples on food insecurity and some of the strategies and that CHWs can have or can use. Again, these resources will be shared with all of you so you can take a look at the strategies and some examples. But I would like to mention a couple of things here which are extremely important. Specifically, if you serve immigrant populations and those who probably are not legally in the United States, and how difficult for them is to have access to healthy food and all the challenges that they have, is extremely important to know sometimes the immigration status of these patients, because these patients can I mean, they are struggling, they are unable to have sometimes a permanent job, they are moving from place to place, they skip meals, they have frustration, and overall, sometimes they don't like to talk about these issues. So it's very important just to make sure that you create the relationship with your patients in order to get all this information. And it's extremely important, again, because of different policies that were in the past, and then patients were less likely to go to the health centers to receive any of the health services. We're not talking only about diabetes or prediabetes. Patients were not going to get vaccines, we're not going to get sometimes the medications that they need for other chronic conditions. And the reason is the public charge issue, and how difficult for them was to understand how to get access to healthcare services. So these are some examples that you can analyze and you can see when you receive your slides. Next slide, please. Again, these are some of the community resources. You have already mentioned some of them, and some of the food programs, the food banks, stamps, and access to housing, and all how you offer your help to your patients and to address some of the social needs. It's very difficult for patients with diabetes and prediabetes. I mean, they are struggling with a condition that is a condition that is not easy sometimes to understand. It's a condition that it requires a lot of education, that requires a lot of understanding, that you have new medications every year, new technology, and they have to learn about all these issues. And at the same time, they need to focus on their social needs, making sure that they have a stable housing, making sure that they have access to healthcare. So it is a very complex condition that it needs it needs the collaboration and the work of a team to provide to cover not only the clinical needs of your patient, but the social needs of your patients as well. Next slide. So our next session is going to be on April the 22nd. Is going to be the CSWS of the future, virtual visits and technology. That one, it will be next Monday at 1 p.m. This is the registration link. If you haven't registered, you can register at any time. Again, all these resources will be sent to you via email, and it will be another session on how the pandemic has changed somehow the way that we are communicating with our patients, and whether this is something that it will continue. At the same time that we are going to discuss some of the new, or what is going to happen in 5 years, 10 years, what the needs of the patients will be, what if there is any new condition, or if there will be something else that we need to start thinking how we are going to address. So if you have any ideas, if you are looking some changes, if you are looking some emerging issues, it would be a very good opportunity to share your thoughts and to share your experience as well. Next slide. This is our contact information. If you have any questions, you can either contact me or you can contact Fide, who's been working behind the scene, providing help and working on the logistics. You can also contact either by email, or you can call the National Center for Health and Public Housing. The phone is 703-812-5822. Next slide. Please make sure that you complete the post survey for this session. We are very happy to have you all, and we are always happy to hear from you. If you have any additional questions or comments, please send us our way, and we will make sure that we respond to each of the emails that we receive. Thank you so much again for participating on today's session, and have a great afternoon.